I think we should start now. I'm not sure whether this was the signal for me. I guess so. My name is Ulrich Diernagel. I'm the head of the Quest Center at the BIH, and I'm very happy to welcome everyone to this last BIH lecture of the year. And I'm especially pleased that we have Gordon Guyatt as a speaker. I'll just introduce him. I think most people already know him, but I'll do it anyway. So Professor Guyatt is Professor of Health Research Methods, Evidence and Impact at McMaster University in Hamilton, Ontario. He has devoted his career to the cause that only high-quality evidence should guide medical decisions. And his work pushed fellow doctors to base treatments on stronger evidence, particularly randomized controlled trials, the gold standard of research design. His contributions to evidence-based medicine and clinical epidemiology, including improving the methods of randomized trials, measuring how patients are feeling, systematic reviews, and clinical practice guidelines, as well as grading the quality of evidence, have been cited hundreds of thousands of times, making him one of the most cited living scientists in the world. Because of his stellar achievements in improving the quality of clinical research and bringing evidence to medicine, he was awarded many prizes, and I'm particularly proud to say that in 2022, last year, he was the winner of the Einstein Award for promoting quality in research. We're looking forward very much to an exciting event. For the first time, the BIH lecture will be interactive with questions to you in the audience. And I'll give a big shout out to Liam Yao, who has set this up and is in control. But in addition, of course, we will have a discussion at the end where the audience can comment and ask questions. So please post questions in the chat if you have them. And Gordon just told me that he is also happy to be interrupted if there are pressing questions. So you just post them as urgent in the chat, and I will then hand your question over to Gordon, and he's happy to answer it while he's in his talk. So, Gordon, without further ado, please now tell us how to avoid being misled by the medical literature.
Okay, thank you very much. I'm delighted to be with you. And hopefully you have now a full screen version of the presentation, how to avoid being misled.
Yes.
And as Uli has just told you, just put a question in the chat as we go along. Happy to interact and clarify. So, conflict of interest. I've been a consultant with UpToDate for the last 15 years, and my role is to help them be as evidence-based as possible. And I will be referring to UpToDate, so you should be aware that whatever I say is no doubt influenced by my conflict of interest. So I'm going to address three issues in terms of the risk of being misled. Can you trust authors' conclusions? And what to do if you can't? Can you prescribe on the basis of the effect on surrogate outcomes? And what to do if you can't? Can you trust results of trials stopped early for benefit? And what to do if you can't? So, first story I'm going to tell you goes back 20 years in a study published in JAMA. They looked at 25 reviews in the Cochrane database, and in those 25 reviews, they looked at 370 randomized trials. This was a random, they got these from a random selection of 167 of what was then over 1,000 reviews in the Cochrane database. It's now close to 10,000. They excluded studies, they excluded reviews that included less than 5 studies, that didn't have variability in one risk of bias criteria, concealment of randomization. They only wanted binary outcomes, and they only wanted drugs. When they got their studies, they identified the sources of the funding, the effect on the primary outcome, magnitude of the effect, the adverse effects, and methodologic quality as manifested in concealment or lack of concealment, and blinding or lack of blinding. And one other thing that they abstracted, The additional thing that they extracted is how enthusiastic the authors were about the treatment that they were investigating. And they had a 6-point scale in which number 1 was the experimental intervention was highly preferred. 5 points preferred, but less enthusiastically. 4 points probably better, but not much. And then 3, 2, and 1 would be the experimental intervention was worse than the comparator. Here are the key results stratified by the funding of the trial. And I would like to focus on the first 2 columns and the final column. So 67 of their trials were funded by not-for-profit organizations. And of those, 11 of 67, or 16.4%, were enthusiastic, 6 points on this 6-point scale. So a small minority were very enthusiastic. If they didn't report the funding, or if they were funded by not-for-profit and for-profit organizations, it jumped up to 30 to 35% of the trials were enthusiastic. And if it was funded by for-profit organizations, it was 50% strong endorsement, 6 on that 6-point scale. So there's an absolutely clear gradient of enthusiasm according to funding. What could be the possible explanations? So I'd like you to think about it for a second. And I believe our first poll, Liam, is about what the possibilities might be. I believe in this poll, you can endorse any of those that we're going to present to you that you think are possible. I don't see the poll on my screen, Liam. I presume it's going up?
Yes, I have launched the poll.
Okay, excellent. So Liam, why don't you wait a few seconds for people to, so I'd like the polling, I hope, will keep you engaged and interested, but please do it quickly. Don't want to lose too much time waiting for you to have your answers. So Liam, in just a few seconds, I don't know if you can put up the results of the poll so I see it on my screen, or just tell me what the results are.
Okay, I have shared the results. Can you see that?
I can't, so why don't you just tell me?
Okay, I think for 77% of the people choose the biased interpretation, the last option, and for, let me check. It's because this is a multiple choice, so we have about 50% of the people choose the industry supervised elective trials, and we have 10% choose the first option, industry trial, better down, and the 3% choose the second one, industry trial show lot effect.
Okay. Did you set it up so people could choose more than one?
Yes, it's multiple choice.
Okay. Well, multiple choices, sometimes you can just choose one, or you can choose them all. Anyway, hopefully that was choose them all. Anyway, the bottom line answer is that it's all of them. All of those are possibilities that explain this. So maybe the trials were better done, less risk of bias, and larger if they were done by industry, because industry has a lot more resources. If that's true, the stronger inferences from the industry trials could be quite legitimate. Or the trials, because the industry had done better preparatory work and only brought to trial the ones that all the prior work had suggested were likely to be winners, they would show more benefits and less harms. And the results, because they were preferable, would warrant strong recommendations. Or another less pleasant reason that the trials published have a greater proportion that warrant strong recommendations is because the industry suppresses the trials that don't warrant strong recommendations. So that makes it legitimate that they would have a higher proportion, but unfortunately for not very many attractive reasons. So if all those so far would warrant more strong recommendations with industry, or actually the industry trials do not yield more powerful results in terms of better benefits or less harms, they yield the same thing, and what's going on is biased interpretation. How could the authors have addressed these competing explanations? Number one, that the trials are better and give better results, and so they warrant a stronger recommendation or biased interpretation. Well, what they did was to do what is called an adjusted analysis, and they adjusted and they found if there was a bigger beneficial effect, it was more likely to be a strong recommendation. Good, that's the way it should be. If there was blinding, it was more likely to be a strong recommendation. Good, stronger inference is warranted with blinding. After adjustment, the odds of a strong recommendation by the industry-funded trials was an odds ratio of over 5. 5 times greater odds with the same benefits and the same harms and the same methodologic quality. So clearly, part of this explanation, maybe a very big part, is biased interpretation. So we have, that study was done 20 years ago. Our group has launched a revision, a replication of this, and in the Einstein Foundation's look for the work that will improve the quality of care, emphasized the importance of replication. So we decided to replicate. So other explanations of the previous results was the topics might differ and the outcome might differ, patient important versus surrogate. You'll hear more about that later. So our study has a stronger design. Studies are nested within the meta-analysis, and we're going to adjust. We have adjusted our analysis for outcome. Haven't submitted yet, so this is preliminary. You're getting a picture of what's going to appear in a publication shortly, we hope. We looked at 470 randomized trials and 20 Cochrane reviews. And in adjusted analysis, the odds of a strong inference was, after adjustment for the quality and magnitude of effects, an odds ratio even bigger than previous, 7.1. That was for profit versus not for profit, mixed of unknown versus not for profit, was still 3.7. Bottom line, it is clear that the strong recommendations that come from industry studies are in substantial part biased interpretation. So what's the conclusion? You cannot trust the discussion in studies that are industry funded. They are going to be biased. So you got to bypass the discussion. Well, what can you do then? You might read the methods and results, but most of us don't have the time or the training to read the methods and results. So as a result, what we need to do is go to trustworthy sources of the interpretation of that evidence, which you're not going to get from authors who are funded by the industry. Where might you go? I've already confessed my major conflict of interest, but since I've been trying to get up to date for the last 15 years to be evidence-based, I have to believe they're doing a not too bad job. So that would be one source you could go to, or your favorite trustworthy guideline, or in an individual instance, a relevant systematic review. All would be options where you could go to get a credible interpretation of the results. So that study, that is issue 1. I'm now moving to issue 2. Issue 2 focuses on outcomes, which can be classified as either patient important to patients, or surrogate outcome. Patient-important outcomes are things like mortality, stroke, pain, quality of life. Surrogate outcomes are not in themselves important, but are associated with patient-important outcomes. And what we hope is that if we have an intervention that moves the surrogate in the right direction, it will also move patient-important outcomes in the right direction. Surrogates are blood tests like hemoglobin A1C, imaging like bone density, measurement of cardiac output, another blood test, serum uric acid. These surrogates are often biologically compelling. Typically, observational studies show association suggesting a causal relationship between the surrogate and patient important. And if there is a causal relationship, if we have a drug that improves the surrogate, it should improve the patient important outcome. Compelling logic and practically compelling as well. If you do a trial with a surrogate instead of a patient important, you can markedly decrease the duration and your sample size and cost of RCTs. Sounds like a real winner. So, first of all, we better be able to, if we're going to talk about surrogates, recognize a surrogate when we see it. A surrogate, let's assume a particular intervention were associated with burden and harm. And the outcome of interest is the only thing to change. Nothing else changes. Might patients be interested if that were the only thing to change? If the answer is yes, despite burdens and harms, if there were a benefit in that outcome, they might be interested, then the outcome is patient important. If they would not be interested, it would be a surrogate. I will briefly present and give you a second just to decide, is this a surrogate or patient important? Is blood pressure a surrogate outcome or patient important? Well, as it turns out, it's a surrogate for things like stroke, MI, and death. We believe that if we lower blood pressure, the consequences will be reduction in things that are important to patients like stroke, myocardial infarction, and death. Heart failure exacerbation, clearly patient important. Cardiac output, surrogate for quality of life, heart failure exacerbations, and mortality from heart failure. Hip fracture, clearly patient important. Vertebral fracture, well, probably not by itself, because it's quite possible that people have asymptomatic vertebral fractures which aren't important. Vertebral fractures are important if they influence the patient important outcomes of pain or deformity. Development or increase in albuminuria, a very popular outcome in nephrology trials, but a surrogate for the need for renal replacement therapy. Asymptomatic DVT, in and of itself not patient important, but a surrogate for symptomatic DVT and pulmonary emboli. So these are examples of outcomes that are important to patients and outcomes that are surrogate, because if they were the only thing to change, nothing else would improve for the patients, and there were harms or burdens, patients would not be interested if the surrogate were the only one to change. That's the litmus test. Development of diabetes, I will talk about more. And so here are examples of failed surrogates. Okay, on the left, you have the condition of interest, then the intervention, then the surrogate, then the patient important outcome. So acanide and flecainide were antiarrhythmic drugs which obliterated the surrogate nasty looking arrhythmias after myocardial infarction. But when tested in randomized trials with the full anticipation they would decrease mortality from arrhythmia, from lethal arrhythmias, increased mortality. Heart failure, you have a number of drugs there that all improve hemodynamic function, either reducing afterload or improving cardiac output, or both. When tested in randomized trials with an anticipation of decreased mortality, they all increased mortality. In osteoporosis, sodium fluoride was given. It improves bone density. Unfortunately, it increases, not decreases, fractures. Clofibrate lowers the cholesterol and LDL and was anticipated to lower mortality, in fact, increased. Hormone replacement therapy, it does good things, increasing HDL, lowering LDL, but no effect or perhaps an increase in coronary events. In ARDS, nitric oxide improves oxygenation, and at one stage in the late 1990s was widely used by European intensivists. Ultimately, its point estimate in a meta-analysis suggested a possible increase in mortality and a definitive demonstration of increase in renal failure. So bottom line, lots of stories of failed surrogates. I'll tell you a couple of more. So one is the drug rosiglitazone on the frequency of diabetes in patients with impaired glucose tolerance. In this trial, they enrolled over 5,000 patients with abnormal glucose tolerance. which were randomized to lifestyle advice or advice plus rosiglitazone and followed for 3 to 5 years. Here are the results. They had a composite outcome, which one could question, which was the development of diabetes and death. There were very few deaths, so really all the action is on the development of diabetes. That their primary outcome, a big reduction in the development of diabetes, 26% in placebo, 11.6 in rosiglitazone. That's a 60% hazard reduction with quite a narrow confidence interval, upper boundary, at least a 54% hazard reduction, and a p-value of 1 in 10,000. What a great way to prevent diabetes. And that didn't matter whether it was diagnosed by a glucose tolerance test or physician diagnosed. Big effects. Well, you might say, let's do the test. Let's say you told patients, maybe I'll stay here for a minute, you told patients that I can save you a diagnosis of diabetes, but unfortunately, you'll have just as many cardiovascular, microvascular, and macrovascular events. Are you interested? Maybe not. So what happened to the things that are really important to patients? Myocardial infarctions, more with rosiglitazone. Stroke, cardiovascular death, heart failure, angina, revascularization, all more with rosiglitazone, not less. None of them significant, except for one, heart failure, which occurred rarely, but it's all going in the wrong direction. Nevertheless, here is what the authors say in their Lancet publication in the discussion. This large prospective blinded international clinical trial shows that 8 milligrams of rosiglitazone together with lifestyle recommendations substantially reduces the risk of diabetes or death by 60% in individuals at high risk for diabetes. The absolute risk difference is 14.4, which means that for every 7 people with impaired from fasting glucose who are prescribed rosiglitazone, 1 will be prevented for developing diabetes. So another poll. Do you think, if you look at what the authors have just said in the discussion, that they are telling you, this time, Liam, I can see the poll. They are telling you that, they are effectively telling you that there's a strong indication for giving rosiglitazone to everybody, a week for some, week recommendation for some, or not indicated. What do people think? Okay. I'm not asking you what you think. I'm asking you what you think the authors are indicating in their discussion. Okay, very good. So over 50% think that the authors are making a strong recommendation for everybody. About a quarter think it's a week. They're saying it's a week recommendation. And about 20% think that the authors are telling you it's not indicated. Okay, very good. So we will move on. Thank you very much for participating in the poll. That's going to make it work better. Okay, so think of a conversation now between a doctor and a patient. The doctor has just been visited by a representative of the pharmaceutical industry who has told the doctor about this study and says, rosiglitazone, when your people have blood sugars that are near our threshold where we call it diabetes, rosiglitazone will prevent diabetes. You should be giving it to all your patients. The doctor is impressed, and the next patient with a blood sugar near the threshold says, doctor, what do I gain by taking rosiglitazone? The doctor says, well, you have less chance of developing diabetes. Doctor, what happens if I get diabetes? Well, you have to take a drug if you get diabetes. The same drug I'm taking to prevent diabetes? Well, I could give you a drug like metformin, which has less problems than the rosiglitazone. Doctor, I don't get it. I'll take a drug every day for 3 years to lower my risk of taking the same or a less toxic drug from 25 to 10%. Something seems wrong here. Well, something seems wrong to my colleague Victor Montori and me, and we published a follow-up paper in the BMJ The acronym for this trial was DREAM, and our commentary was titled Waking Up from the Dream of Preventing Diabetes with Drugs. And what we did is a very informal decision analysis in which we said, what will happen if you give 1,000 people the drug to prevent diabetes or don't give it to them? The difference in use of the drug is going to be over 26,000 patient years. New diagnosis of diabetes, you've already seen that, just over 1,000 with the drug, 2,500 a quarter in those who do not get the drug. Anxiety about diabetes, we're not sure. Cost and inconvenience of self-monitoring, we're not sure. MI, stroke, and cardiovascular death, a suggestion, if anything, of an increase. Heart failure at 3 years, a small absolute number, but a significant increase in heart failure with the rosiglitazone. What about microvascular, kidney, eyes, neuropathy? We don't know. I haven't told you yet, more peripheral edema and more weight gain in those given rosiglitazone, and a worry about rare adverse effects of rosiglitazone, fractures, and macular edema. So there is the actual picture of what happens with 10,000 patients receiving rosiglitazone for 3 years or not doing so. When you see those results, what do you think? Should we be making a strong recommendation for rosiglitazone for everybody, a week for some, or not indicated? What do you think? So we're running about 2/3 not indicated, and 1/3 thinking there's a weak recommendation for rosiglitazone would be warranted. Okay, very good. Thank you very much for quickly voting. I really appreciate it. And your vote shows that you disagree with the authors. The author, most of you, majority anyway, thought that the authors were making a strong recommendation, and that is not what you think is warranted when you've reviewed the picture. What went wrong? Well, number one, guess who funded the study? The makers of rosiglitazone. And we've already seen that when authors are funded by the industry, they will be biased in their interpretation. But these were smart people. They were actually from my institution. But I would argue that the problem is, I would argue that what has gone wrong is the authors were not making a clear distinction between the surrogate of the development of diabetes and the patient-important outcomes. And by focusing on the surrogate, they came to a very misleading advice that they gave to the authors in that Lancet publication. So, to show how badly we've gone wrong, in my opinion, with the surrogate of lowering blood glucose for macro and microvascular, metformin has a big effect on lowering blood glucose, no effect on cardiovascular events. Insulin has the biggest effect around in lowering blood glucose. And these are all type 2 diabetes. No benefit on reducing cardiovascular events. DPP-4 inhibitors, sulfonylurea, thiazolidones, all substantial effects on lowering blood glucose, either no effect on patient-important outcomes or with rosiglitazone, when people did a meta-analysis, probable harm. SGLT2 inhibitors, only a small effect on lowering, less than any of the other drugs, but a substantial effect on reducing cardiovascular events. GLP-1 agonists, the same thing. No relation between lowering blood glucose. Some drugs, great lowering blood glucose, no effect on the outcomes of importance. Other drugs, less effect, but they lower the important outcomes. Not a good surrogate. Okay, so another surrogate, I'm looking at time here to make sure, I think I can tell you about this one as well. Okay, patients with cardiovascular disease. Higher HDL associated with lower cardiovascular risk. Strongly agree, or disagree? Poll, please, Lee. Okay. most strongly agree, or a few strongly agree, most agree, some disagree. As it turns out, there is a high association between HDL, shown in many observational studies, that the higher your HDL, the lower your risk of cardiovascular disease. The lower your HDL, the greater your risk of cardiovascular disease. That is, turns out, those of you who said that this is the case were right. That is very well established. Okay, now, given that lowering HDL, increasing higher HDLs are associated with lower cardiovascular disease, it then follows that raising HDL should decrease cardiovascular risk. Strongly agree, agree, or disagree? Okay, great. People are getting the message. Some third agree, but now we have 60% who disagree. And that we are saying is the message of this is that we have to be skeptical. And let me tell you what happened. I think this is personally, I think this is a great story. Okay, so what happened was back in, I'm just trying to get off my screen the poll. Back in 2011, in the New England Journal, niacin in patients with low HDL cholesterol levels receiving statins. Among these patients, despite a significant improvement in HDL, there was no effect on cardiovascular outcomes. So investigators were disappointed, but they thought, okay, we only had 3,000 patients, that wasn't enough. And the patients probably didn't take it because niacin gives flushing. What if we give a drug, laropipravir, which reduces the flushing? So they said, we'll do a bigger trial and we'll give this drug to prevent the flushing. So they enrolled over 25,000 patients, and they had the effect with the niacin they were hoping for. Substantial increase in HDL, and LDL was actually decreased. Major vascular events, point estimate 4% relative risk reduction, but the confidence interval includes a 3% increase in cardiovascular events. And with 25,000 patients, they got all sorts of side effects they weren't expecting. And with these huge sample size, they were able to detect a decreased and increased incidence of diabetes, serious GI, musculoskeletal, and bleeding, serious adverse effects, all with P's less than 1 in 1,000. Niacin is not good news. Why not? Why didn't it improve cardiovascular outcomes, since it did a nice job with HDL and also some LDL effects? Well, they said its effect is still not too small. So let's use something really potent. So they had developed these cholesterol ester transferase protein drugs that influence this. They lead to big increases in HDL, and they give drops in LDL as well. So they tested one of these, torcetrapib, in a large randomized trial. At 12 months, in patients who received the drug, increase of 72% in HDL, decrease of 25% in LDL. Look at that, p-values less than 1 in 1,000. This is a potent effect on lipids. Unfortunately, there was also an increased risk of cardiovascular events, not decreased as they were expecting. 25% increase, p-value of 1 in 1,000. And it killed people. Increase in death from any cause, 58% in relative increase, p-value 6 in 1,000. Bad news, despite the increase in HDL and the reduction in LDL. What went wrong? Well, as it turns out, they look at, as people do later on, they didn't think of this beforehand, it increases the blood pressure and aldosterone. So they get a new drug, a new one of these trapids, no increase in blood pressure, no increase in aldosterone. And they test this in over 12,000 patients in a nicely done trial. Big increase in HDL and a substantial decrease in LDL, and still no reduction in cardiovascular risk. A hazard ratio of a trifle increase, essentially no difference. As the last I looked, the investigators still can't figure out what's going wrong. So Other problematic surrogates, tests of cognitive function instead of function in Alzheimer's, bone density instead of fractures in osteoporosis, oxygenation instead of mortality in ARDS, asymptomatic versus symptomatic thromboembolism, pulmonary function instead of exacerbations and quality of life instead of in respiratory disease, and the diabetes that you've seen vividly, and the lipids that you have seen vividly. Big problems. So when you see what to do if the study has only used a surrogate, you got to be skeptical. You've got to realize that you have only low quality evidence for effects on patient-important outcome. If there is established effective treatment, stick with it, don't switch. If no established treatment, it's a value and preference sensitive choice. You have to tell your patients, maybe this will work, but quite possibly it will not work on the outcomes that are important to you. And they will inevitably come with some harms and burdens. It becomes a value and preference sensitive choice. Okay, the third issue I am going to raise, which is the story I'm going to tell, or the first story I'm going to tell, is 5 versus 4 courses of therapy for acute myeloid leukemia. Acute myeloid leukemia is a nasty illness, very likely to kill you. The chemotherapy is no fun, a lot of toxicity, but if it reduces the mortality, it might be worth it. The investigators who started this trial in the mid-90s, by 1997, they'd enrolled over 200 patients. They found at that point, a 57% reduction in the odds of mortality with these 5 versus 4 courses. Excuse me. Question to you for ethical reasons. I thought I pulled this poll, but okay, we'll do it. Should people have stopped? Should the authors have said, let's stop the trial? Okay, we're seeing this over 50% reduction in dying. It's unethical to continue. Okay, we're splitting about 60%, 50 to 60%. It's still dynamic. Now it's 60% say stop, 40% say continue. So it splits, okay? So near 50-50, half say condition. Well, they kept going. And then they looked again, and the next time they looked, there was still a 53% relative odds reduction in mortality. So we need to get rid of the prior poll and show it again if we can do that, Liam. Now, what do you think? Now the confidence interval is quite a ways from no effect, and our p-value has gone from 5 in 100 to 3 in 1,000. Should at this result, with this much narrower confidence interval and much lower p-value for mortality, should they stop at this point? Well, we're still coming up with about 50-50, and now it's over 60% say stop. Well, the authors did not take the advice of the majority. They didn't stop. Here's what happened. The poll keeps popping up. I have to get it off my screen. Okay, whoops. Here's what happened. Look at that. The effect was gradually lost, and in the end, a slight increase in mortality with the 5 courses. Had they stopped where the majority of people here thought they should have stopped, they would have promulgated 5 versus 4 courses, increasing the toxicity with no benefit whatsoever. What went wrong? What went wrong is the following. Consider the following: a drug with a true small beneficial effect on the outcome, and you start enrolling people in trials. Well, one trial might go very quickly to the true effect and stay there. Excellent. But because of the play of chance, when there are small numbers, some trial might initially suggest harm and then come back ultimately to the true effect when there's enough patients. Or some trials may show a big effect and ultimately come back to the truth. And what if you say, okay, if it looks like there's a big effect, like in the one we just showed, we are going to stop. If that happens and you look after every patient or event, anytime it crosses that boundary, you stop. 50 years ago or so, statisticians thought that's not a great idea. Let's just look at periodically at 250, 500, 750,000 patients, for instance. Well, that makes the problem not as bad, but anytime you cross that line just by chance, at the time you look, you're going to stop the trial early and overestimate treatment effects. Theoretically, when statisticians have looked at this, trials stopped early overestimate treatment effects.
Gordon, can I just interrupt you because you?
Yes, please.
You asked the audience to
interrupt. Yes,
and
please.
I think we have a relevant question here, and it's from David Shemi. And the question is, if the association of the surrogate with relevant outcomes is not strong enough, what is the role of phase 2 trials? Is there a need for them?
Okay, excellent question. And I would say it depends on the situation. The understanding of the biology will make a difference, but I would be reluctant. We have all these examples where the surrogate, despite compelling evidence of the associations, big effects of the association on the surrogate and the patient-important outcome, it doesn't work. I'm not a drug developer, but if I were a drug developer, I think I would not go there, given all the failures, I would not go there unless the association were very strong. And even then, of course, it would have to be tested because of what we've seen. But I personally would restrict to that. Okay, hope that answers the question. If not, at the end, you can clarify and bring it up again. So, great question. Thank you very much. So, returning now to the stopping early. So, we got a problem with stopping early. And in fact, what we have shown, we took a large number of trials where they had both trials that were stopped early and trials that were not stopped early. And what this shows is the ratio of relative risk, where this means below here, it means that there was a 50% bigger effect in the trials stopped early than the trials not stopped early. And up to, and then it's a smaller overestimates, no overestimates. So when you're under 100 and even 200 patients, lots and lots of big overestimates. So I should say not patient, number of events. When you get over 200 events, the overestimates are still substantial, but smaller. And once you get to 500 events, then the overestimates are minimal. So the bottom line of this is when you get the really huge overestimates of effect on trials stopped early is when they have few events. So bottom line, be aware that trials stopped early likely overestimates effect. And if there's a small number of events, it's very likely to be a big overestimate and there may be no benefit at all. These stopped early trials, if they get up to very large number of events like 500, don't have to worry. But with small numbers of events, they only give low certainty evidence. You have to assume a smaller effect than what they're saying, or maybe no effect at all, and guide patients accordingly. So the bottom lines of what we have been through in this presentation. So you cannot trust the conclusions of authors who write papers where the trial has been funded by industry. You simply cannot trust it. You need to find your own trustworthy summaries and recommendations. For substitute endpoints, if that's all there is, it is low quality evidence of an effect on patient-important outcomes, and you need to guide your patients accordingly. Trials stopped early for benefit. They will overestimate effects. And when there are relatively few events, under 100, definitely bad news, under 200, still bad news. And you're not really confident until you get over 500 events. And you need to guide your patients accordingly that the estimates that come from the trials are likely overestimates. So thank you very much for listening. Thank you very much for participating in the polls. Really appreciate that. And we have, and I have finished exactly on time, 15 minutes for even with one interruption, I finished on time, and happy to take questions and comments.
Yeah, thanks, Gordon. This was brilliant. Also, with respect to time, I was expecting a disaster.
You were expecting me to go over, weren't you? You were expecting me to go over.
I admit that I was afraid, but this is great because it gives us time to discuss. And actually, there is a thread that is going on regarding this last issue that we brought, overestimation, early stopping. And before I ask my question in this regard, I want to continue the thread that was started with the type 2, the use of type 2 question. And the question that then came afterwards is how, and it's again by Javed Hashemi, how do you assess overestimate in real life? How and what is real true?
You never know. We never know what is real true. That's the start. We are never absolutely confident. But what we need is replicable trials that are done well, low risk of bias, and concealed randomization, blinded, follow patients, enroll enough patients. Single trials almost never enroll enough patients. That's why we need multiple trials summarized in systematic reviews and meta-analysis. And until we have that, and using the great approach to certainty of evidence, under those situations, if you have that, you have high certainty evidence of the effects on benefits and harms. Short of that, we do not know. And what we have to do as clinicians and in advising our patients is to acknowledge our uncertainty, and the more uncertainty, the more the decisions are value and preference sensitive, and make sure that the people have different attitudes toward uncertainty, and we must acknowledge our uncertainty and build that into our conversations with our patients.
Thanks. And let me invite again everyone to pose questions. There are new questions coming in, which I'll read in a second. Mike, what you just said, I think, begs the question related to disease areas and treatments where we have just a few patients. So let me bring in personalized medicine. So, or rare diseases. So if what you just said, wouldn't that mean that there is no way to get to any evidence of that sort that you are asking for in those diseases? Or what's your approach to, let's say, rare diseases?
Unless, okay, so there are instances when one has miraculous effects. They're very, very few, but there are instances. If you if you had 50 patients with a rare disease, when it started in childhood and all the kids were dead by 5, and now you give them a treatment and 50 kids live to 30, okay, you got it. Huge treatments effects. So there are instances, and we know that in medicine. It used to be that when you died, you died. And now we have cardiac resuscitation. You don't need randomized trials to say that cardiac resuscitation. And there are other things, insulin and diabetic ketoacidosis, hip replacement for hip osteoarthritis, insulin for diabetic ketoacidosis, et cetera, et cetera. They're not a lot, but there are situations with huge treatment effects. People tended to do always or almost always very badly. Now a lot of them do reasonably well or very well. You don't need randomized trials. So there are instances, and Great acknowledges that, when there are large or very large treatment effects, and that may happen in rare diseases. But let's assume it doesn't happen. Let's assume you see what seems to be modest effects in small numbers of patients. Well, you're going to be not sure. Now, the issue is not to pretend you're sure, but to acknowledge you're not sure. But then there is the issue what to do about that. And society may say, we're ready to pay large amounts of money for a treatment because we feel sorry for these kids with the rare diseases. I feel sorry for them too. They were ready to pay, even though we are uncertain, we're ready to pay large amounts of money. But let's not pretend we're certain when we're not. So there becomes, just because we're uncertain doesn't mean we shouldn't treat them. It means that we should think very carefully about whether we should, what we're ready to how much uncertainty we're ready to tolerate and still make treatments available in rare diseases. So bottom line is, unless there's these huge effects, you won't get the evidence that leaves us confident of what's going on, and we just have to acknowledge that we're not confident. Doesn't mean we shouldn't give the treatments.
I think that's a very important conversation, which we should have. I mean, within medicine and also in societies, but we don't have it. I mean, at least I don't see it. But and we have a lot of hopes, but no one's really talking about those issues of in the end spending lots of money just on promises, which are, I mean, with good intention, but you can't show that they are actually that there are these effects that are being promised, but we're not having these conversations, I guess, or at least not in Germany. There are now other questions, and so one question, and I can't decipher the name from the initials, but it's probably not important. So the question is, what is the answer for the HDL-LDL versus cardiac events discrepancy? No causative role of lipoproteins in the disease. So here comes a pathophysiological question to you.
Right, and one of the things as an evidence-based guy that I know is not to answer the questions that I'm not qualified to answer. I have no idea, okay? But I would tell you, I sort of follow the literature. So you saw those stories, started out with niacin. Oh, the effect isn't big enough. Oh, patients aren't taking it. Oh, that doesn't seem to be the. So now let's we get something really powerful, the torcetrapin. Oh, that's going to work. Oh, it doesn't work. It actually kills people. Why does it kill people? Oh, we go back and look at the biology. Oh, aldosterone went up, and can't remember what else. Aldosterone went up and something else went wrong. Oh, we didn't think about that beforehand, but now when we get this result, now we go back and we see, okay, now we've got a drug that doesn't do any of this. Okay, works brilliantly in HDL and LDL. Still no effect. I don't follow this literature closely, but I have not seen a compelling explanation. I'm no physiologist, so I couldn't begin to guess. But as far as I know, the physiologists haven't figured it out either.
Okay, thanks. So here's another one. Let's see whether you want to answer it, because it's also going into a direction where you may take the fifth. You mentioned that you would do clinical trials in a different way. Would you think that more care should be taken during preclinical studies, in brackets animal models, organoids, etc., to reassure that as many surrogates are covered as possible?
So yes, you're right. You've gone out of my expertise. I can say, though, intuitively, that given the repeated failures of surrogates, again, if I were involved in drug development, I would do very thorough prior explanations and look for substantial associations before I would think it would be a candidate for a trial. I would be cautious in starting the trials, or you're going to have more, because if you're not, you're going to have more and more repetitions of failures of surrogates.
Okay. Next one is the early stopping effect, in brackets, of making false conclusions on treatment effects, also that pronounced as on the slides if one looks at absolute risk difference rather than relative risk ratio as a decision criterion?
A great point, but sadly, the answer is yes. Okay. So, and as a matter of fact, to show significant results with small numbers, you need very large absolute effects. So with the small numbers, to get these low p-values, you're going to actually have large, and this is a problem. You can't say, oh, we're going to demand a p-value of 1 in 10,000. If you demand a p-value of 1 in 10,000 and you get that with small numbers, there's likely to be huge overestimates of effect in absolute terms.
Thanks. Next one, how do drug approval agencies like the FDA deal with the question if an endpoint is patient relevant? Is it relevant for drug approval at all?
It's highly relevant for drug approval. I was just involved in a dose response systematic review of a drug called gefapixant. Gefapixant reduces cough. Chronic cough, people with bad chronic cough, their lives are awful. That's really a terrible problem. So we really need, and the treatments are that we have now are not any good. So the drug company comes up with a nice biologic mechanism about cough receptors, but it does this drug called gefapixant, does the studies of gefapixant, and measures what they should be measuring, which is patient experience of cough. As it turns out, the effects are marginal. They are small, and there are adverse effects, and the drug is going to be expensive. Goes to the FDA, just went to the FDA a couple of weeks ago after our systematic review and meta-analysis showing these marginal effects. The drug was rejected at the FDA and not moved forward. I don't know if the decision is right or not. There were effects, they were marginal, but the FDA was clearly, their panel was almost unanimous. The only people who voted in favor of it were the two patients on the panel, which is interesting. But at any rate, the bottom line is they were seriously considering not only considering the patient important outcomes of the reduction in cough, but the magnitude of the effect, which is good.
I'm not sure whether you are ready to make treatment recommendations, but the next question is, thinking about implementing your lecture in my practice, should I stop treatment in patients with type 2 diabetes on metformin and insulin and replace that with SGLT2 inhibitors only?
Not necessarily. The reason is that there are two reasons we actually treat diabetes, two broad reasons. One is to prevent macro and microvascular cardiovascular events, but the other is to prevent people from coming to hospital with very elevated blood glucose, either ketotic or not ketotic, and to prevent the symptoms of diabetes like polyuria and polydipsia, the symptoms of glucosuria like polydipsia and polyuria. So there's two things we should be doing. We should be getting the blood glucose down so that people are not symptomatic and don't come into hospital with very high blood glucoses, but that's actually a different set of drugs than we should be using to lower the cardiovascular risk. So you got to do both. If you just give people SGLT2, you'll only lower the blood glucose a little bit. They may still have polyuria, polydipsia, and show up at the hospital with very elevated blood glucose. So conceptually, when we treat diabetes, we should think of these two goals: to minimize the glycosuria, we need one set of drugs for that, and to lower the major macrovascular events, we need other drugs. Now, if the drugs which not such great effects in lowering blood glucose do enough, lower the blood glucose enough, and reduce get the blood sugar enough, great, but that may not be the case. So very still reasonable to start with metformin just to lower the blood glucose and then add in the other drugs to have the effects on lowering major macrovascular events.
Very important clarification. And I think we are zooming in on the last question, which is a very principal one. The question is, which general principles / guidelines do you see to find good surrogate endpoints?
Yes, so good surrogate endpoints, and in my opinion, there are not very many of them, is surrogate endpoints that over and over again have proved in randomized trials that when the surrogate endpoint is lowered, the patient important endpoint is lowered. So blood pressure's very, very good that way. Although, when is the blood pressure low enough, we're not sure. So blood pressure, when we were treating high blood pressures, it kept working. The lower you go, maybe not so much anymore. In HIV, the viral road. Viral road is there every time in the randomized trials, whether it's drug type A or drug type B or drug type C, every time you lower the viral road, you lower the mortality. So that's another one that is very good. So what you need to look for, and there aren't very many, what you need to look for is the consistent association in the trials of lowering the surrogate and lowering the patient important outcome across drug classes. And if that happens, that defines a very trustworthy surrogate. Not too often it's happened.
Thank you very much, and we're in time. I think all the questions from the talk have been answered very concisely. So thanks again for a very stimulating talk. Also, I have to say it was a success that you made it interactive. Thanks also to Liam for making this possible. Thanks to the audience for an engaging discussion also, and I can only conclude by wishing everyone nice holidays, because that's the last chance, at least at the BIH lecture level. Also of course, to Gordon and to Liam. And so have a nice day and thanks again.
Thanks very much.
Bye-bye.
Bye for now.